Thank you. It's great to be here. Moritz and Klaus, fantastic meeting, and it's good to see the room full. So I'm going to talk about changes in sagittal plane alignment after the PAO. So we had a question we wanted to answer is, how is the sagittal plane alignment, the lumbar spine, the pelvis, affected by treatment of hip dysplasia with a PAO? We do know that perhaps there's an increase in pelvic tilt or forward tilt to compensate for DDH in certain patients, and this may decrease after the PAO. So do we need to account for changes in the sagittal plane while performing the PAO or with our correction? To answer this question, we use the EOS to evaluate pre- and post-operative sagittal alignment in PAO patients. There were 55 patients. We used it preoperatively and 12 months postoperative, and we did sitting and standing hips to ankle EOS. We wanted to get the whole lumbar spine all the way down through the knee. It's the same protocol they use in arthroplasty at our center. We measured the pre- and postoperative pelvic index, lumbar lordosis, pelvic tilt, L1 pelvic angle, and PSSI index, so a lot of different indexes to measure the position of the pelvis. And we looked for a correlation between pelvic incidence and LCE, or anterior center edge angle. And we looked at changes in lumbar lordosis from sitting to standing measurements. We did a prior study that we presented here a few years ago on 25 patients, but we didn't have a complete data set. Here's our measurements: sacral slope, which is a horizontal line, and the angle is between that and the S1 end plate. The pelvic tilt, which is a vertical line from the center of the S1 end plate to the center of the hip joint. Pelvic incidence, which should remain unchanged throughout life in a normal circumstance, but this is a 90-degree angle to the sacral slope to the center of the femoral head. And L1 pelvic angle, which is just an overall alignment of the lumbar spine, and lumbar lordosis from L1 to S1. And then we measured the PSSI index. This was described by Ira in a paper. We measured the distance between a line at the lower portion of the SI joints to the top of the symphysis. This can also be done in a ratio. What we found in results is there was no significant change overall in the pre- and postoperative standing or sitting lumbar lordosis after PAO. We also found no change in pre- and postoperative lordosis when you went from sitting to standing, and no correlation between pelvic incidence and lateral center edge angle. We found no significant change again in the pelvic tilt, pre- and postoperative standing or sitting. We did see, though, an increase in the pelvic incidence from pre to post-op, and this was consistent with our prior study, and it's basically from anteriorization of the hip center with the PAO. We found no change for the whole group with the PSSI index in all patients, except a change in those that had had bilateral PAOs with bilateral dysplasia. So if they had bilateral dysplasia and only one PAO, the pelvis stayed in its position, but after the second PAO, the correction, there was less inlet view, so they splinted less and they tended to change their pelvic tilt slightly, and this was consistent with the study done by Ira. And what about these subgroup patients? So here's an example of a patient after the second PAO. You can see there's less pelvic flexion, so the sacrum is in a different position over the symphysis, and this happens through pelvic tilt and lumbar lordosis changes in this group. What about lumbar flexibility? Well, we looked at it from the lumbar alignment from sitting to standing, and in the stiffer lumbar spine, so patients with less change in lumbar lordosis from sitting to standing, in those patients, we actually found a change in that group where there was more pelvic or more lumbar motion post-op, and I'll show that. So there was a significant change in lordosis from sitting to standing postoperatively, and a significant change in the pelvic tilt from sitting to standing postoperatively after a PAO in the stiffer spines. Patients with more change in lumbar lordosis, so basically very flexible lumbar spine from sitting to standing, they did not change after PAO. So here's an example of somebody who preoperative standing and sitting has the same amount of lumbar lordosis. So that's a sort of a stiff spine that's not moving very well. After the PAO, they're able to flatten out their spine. So there's more change from sitting to standing, which either means that they were splinting before, even in the sitting position, and we know some patients after PAO, they tell you the sitting is better, and maybe their spine feels better, or with the anterior correction, we force the pelvis this way, and the lumbar spine would flatten out. So with the increase of pelvic incidence, the hip center does move slightly anterior, and we don't really know how this might affect the muscles or the iliopsoas coming over the anterior aspect of the hip. And we do know that although there is some change in lumbar lordosis after bilateral PAOs, the sagittal alignment is relatively unchanged, so you don't need to hedge when you get your images in the operating room and decide where to put the acetabular fragment. As I mentioned, so since the pelvic position is relatively constant, preoperative, intraop, and postoperative, you can pretty much guarantee that what you're seeing in the operating room could be what you might see 6 months or a year later, except perhaps in the PAO patient, in the bilateral ones. And we use the RadLink software, and we measure the index, so the PSSI index, so that's percentage change. So we measure the standing x-ray, and then intra-op we get a fluoro view. We want to make sure the pelvic position is the same on those two views, and we know from a study that it's going to be same 6 months later. So that helps us decide what to do with acetabular version to make sure we have the correct version and the correct anterior wall index. So in summary, there's a slight increase in pelvic incidence after a PAO. Patients with bilateral diagnosis and bilateral PAOs might have some compensation, but in general, the sagittal alignment is relatively unchanged after a PAO. Thank you.